So, Graves of ophthalmopathy. The text has been taken from the Oxford Handbook of Endocrinology. It's an organ-specific autoimmune disorder characterized by the swelling of the extraorbicular muscles, lymphocytic infiltration, late fibrosis, muscle tethering, and proliferation of the orbital fat and connective tissue. The volume of both the extraocular muscles and retroorbital connective and adipose tissue is increased due to inflammation and the accumulation of hydrophilic GAGs, principally high hyaluronic acid, in these tissues. GAG secretion by fibroblasts is increased by activated T cell cytokines such as tumor necrosis factor alpha and interferon gamma, implying that the T cell activation is an important factor of this immunopathology. The accumulation of GAG causes a change in osmotic pressure, which in turn leads to a fluid accumulation and an increase in pressure within the orbit. These changes displace the eyeball forward and can also interfere with the function of the extraocular muscles and the venous drainage of the orbits. Clinically evident in 20% of the patients, but a further 30% may have evidence on imaging, mostly bilateral but often asymmetrical, and 15% have a unilateral disease. Most have mild self-limiting disease, but 75% more males and the elderly have a severe disease that threatens the sight. The natural history is variable, with spontaneous improvement in 66%, no change in 20%, and worsening in 14%. Incidence is higher in females, except for the severe disease, where there is equal sex incidence. Prevalence is decreasing, probably associated with decreased smoking. This bimodal age distribution in females, with peak onsets between 40 to 45 years and 60 to 64 years. In males, a single peak incidence occurs at 65 to 69 years. There are two stages in the development of the disease, which can be recognized as an active inflammatory, that is dynamic stage, and the relatively quiescent static stage. The appearance of eye disease follows a different time course to thyroid dysfunction, and in a minority, there is a lag period between the presentation of hyperthyroidism and the appearance of eye signs. 85% of the patients develop Graves' disease within the first 18 months of Graves' ophthalmopathy developing, 25% precedes, and 40% following. 5% of the patients with Graves' ophthalmopathy have hypothyroidism, and 5% are euthyroid. High levels of TSH receptor antibodies identify high-risk patients. Current smokers, those patients who smoke greater than 20 cigarettes per day, are more likely to develop ophthalmopathy. Continuous smoking and uncontrolled hyperthyroidism or hypothyroidism moderately worsen Graves' ophthalmopathy. The role of an endocrinologist during a routine review of the Graves' patients is to record accurately the clinical features of Graves' eye disease and to identify ocular emergencies such as a corneal ulceration, congestive ophthalmopathy, and the optic neuropathy, which should be referred urgently to an ophthalmologist, preferably in the multidisciplinary clinical setting. So the clinical features include retraction of the eyelids is extremely common in thyroid eye disease. The margin of the upper eyelid normally rests about 2 millimeters below the limbus, and retraction can be suspected if the lid margin is either level with or above the superior limbus, allowing the sclera to be visible. The lower lid normally rests at the inferior limbus, and the retraction is suspected when the sclera shows above the lid. Proptosis or exophthalmos can result in failure of the lid closure, increasing the likelihood of exposure keratitis, and the common symptoms of gritty eyes. This can be confirmed with fluorescein or rose bangle stain. As papilledema can occur, fundoscopy should be performed. Proptosis may result in periorbital edema and chemosis because the displaced orbit results in less efficient orbital drainage. Persistent visual blurring may indicate an optic neuropathy and requires urgent treatment. Severe conjunctival pain may indicate corneal ulceration requiring urgent referral. So, assessment of the severity of Graves' ophthalmopathy. So, it could be mild, moderate, and sight-threatening. With mild Graves' ophthalmopathy, there is minor late retraction, which is less than 2 millimeter. There is mild soft tissue involvement. Exophthalmos is less than 3 millimeter. There is no or transient diplopia. There is mild corneal exposure. While in moderate Koreb's ophthalmopathy, the lid retraction is greater than 2 millimeter, is moderate to severe soft tissue involvement, exophthalmos is greater than 3 millimeter, and there is diplopia. And in case of sight-threatening Krebs ophthalmopathy, there is optic neuropathy, corneal breakdown, and congestive ophthalmopathy. Investigation of proptosis include documentation using a Hartel exophthalmometer. The feet of the apparatus are placed against the lateral orbital margin as defined by the zygomatic bones. The marker on the body of the exophthalmometer is then superimposed on the reflection of the contralateral one by adjusting the scale. The position of each cornea can be read off against the reflections on the millimeter scale is seen on the mirror of the apparatus. A normal result is generally taken as being less than 20 millimeter, less than 80 millimeter in Asians, less than 22 millimeter in Afro-Caribbeans. A reading of 21 millimeter or more is abnormal, and a difference of 2 millimeter between the eyes is suspicious. Soft tissue involvement. Soft tissue signs and symptoms include conjunctival hyperemia, chemosis, and foreign body sensation. The soft tissue changes uh, can be secondary to exposure, but often results in the absence of these etiological factors. CT or MRI scan of the orbit demonstrates enlargement of the extraocular muscles, and this can be useful in cases of diagnostic difficulty. This is also more accurate for the demonstration of the proptosis. In of, Patients may complain of diplopia due to ocular muscle dysfunction caused by either edema during the early active phase or fibrosis during the later phase. Assessment using Hess chart can be helpful. Intra-optic pressure may increase on upgaze and result in compression of the globe by the fibrotic inferior rectus muscle. Ocular mobility may be restricted by edema during the active inflammatory phase or by fibrosis during the fibrotic phase. The two most common findings are defective elevation caused by the fibrotic contraction of the inferior rectus muscle and a convergence defect caused by the fibrotic contraction of the medial rectus. Disorders of the medial rectus, superior rectus, and lateral rectus muscle produce typical signs of defective adduction, depression, and abduction, respectively. Examining of possible optic neuropathy include history of poor vision, a recent or rapid change in vision, or a poor color vision are the reasons for the prompt referral. A visual acuity of less than 6 by 18 warrants referral to an ophthalmologist. For color vision, each eye should be evaluated by using a simple 15-plate Ishara color chart test. Color vision is a subtle indicator of optic nerve function. Failure to identify greater than two of the plates with either eye is an indication for the referral. This is unhelpful in the 8% of the males who may be colorblind. Marcus gun pupil. The swinging flashlight test detects the presence of an afferent pupillary defect associated with optic nerve compression. So, the medical treatment of Graves' ophthalmopathy. Simple treatment for lid retraction include most patients do not require any treatment since clinical signs usually improve with the treatment of hyperthyroidism or spontaneously with time. That is in case of 40% of the patients. Sunglasses help with photophobia and excess tears. In patients with significant lid retraction and exposure keratopathy, topical lubricants improve symptoms. Surgery to reduce the vertical lid fissures can be considered when patient is euthyroid. Botulinum toxin injection may reduce persistent upper lid retraction. Head elevation during sleep and diuretics may help congestion. Acute treatment for the active ophthalmopathy, that is sight-threatening. Effectiveness is more likely in those with diplopia at neutral gaze and inflammatory components to ophthalmoplegia. Glucocorticoids at high doses, that is 60 to 80 mg per day, improve ophthalmopathy in 60 to 75% of the cases. IV glucocorticoid pulse therapy has also been used and may have the advantage of fewer side effects than high oral doses of prednisolone, that is 0.5 gram methylprednisolone weekly for 6 weeks, followed by 0.25 gram weekly for 6 weeks with monitoring of liver function test, um, PPIs, and bisphosphonate. The advantage of IV over the oral glucocorticoid was also demonstrated in a meta-analysis of four trials. IV steroids are significantly better in reducing clinical activity scores. The advantage was mostly due to improvement in patients with severe ophthalmopathy. Adverse events were more common in patients receiving oral therapy, and high doses have been seen to induce the liver failure. If high-dose oral prednisolone treatment, uh, if there is a high-dose oral prednisolone treatment is given, then it should be given for 2 weeks and then tapered gradually. Methylprednisolone IV is given at a maximum dose of 8 gram as the risk of hepatic necrosis is seen at a higher doses. Steroid-sparing agents used in the long-term therapy include mycophenolate, azathioprine, and cyclosporine, but there are little data suggesting which is more effective. Urgent referral to an ophthalmologist is indicated for any suspicion of optic neuropathy or corneal ulceration. Multidisciplinary clinics are strongly advised. And orbital radiopathy. Indications for the lens-sparing orbital radiopathy are similar to those for the high-dose steroids. Radiotherapy works by killing retroorbital T cells. 20 gray delivered over 10 fractions is the standard regimen. Treatment with both radiotherapy and glucocorticoids is more effective than either alone, and it is effective in 60% of the cases less than 40 years of age. Other medical therapies include selenium may improve symptoms in patients with mild grades of ophthalmopathy, as illustrated by the results of the randomized trial of selenium, in which 100 microgram of selenium was given 2 times a day, pentoxifylline, or the placebo. After 6 months of treatment, eyelid aperture and soft tissue signs significantly improved in patients taking selenium versus placebo. Compared with placebo, selenium also significantly improved quality of life, as assessed by the Graves Ophthalmopathy Quality of Life Questionnaire. Evaluation at 12 months confirmed the findings at 6 months. A number of reports have indicated that some patients with Graves' ophthalmopathy may respond to B cell depletion induced by the rituximab, which is a monoclonal antibody directed against the B cell CD20 molecule. Rituximab induces a fall in TSH receptor antibody levels and depletion of the B cells in the retroorbital tissues, not just the periphery. Although high doses of this antibody may be associated with severe side effects from the profound immunosuppression, it is possible that much lower doses may be effective in Graves' ophthalmopathy to avoid such effects. This approach to the treatment of severe eye disease is currently undergoing larger trials. Preliminary results from these trials suggest efficacy in some, but not all patients. Other immunosuppressive regimens have no proven place in the general management of Graves' ophthalmopathy. Use of depot octreotide have been shown to be of no benefit in the management. Now, the surgical treatment of Graves' ophthalmopathy. Surgery for decompression. Orbital decompression may be indicated for urgent treatment of optic neuropathy. Posterior medial wall of the orbit is usually removed. Complications include dysmotility of the eye, blindness, orbital cellulitis, CSF leak, cerebral hematoma, obstruction to the nasolacrimal flow, and anosmia. And the surgery for the strabismus should be performed after any necessary orbital decompression. The aim is to allow correct binocular vision. It is performed when the eyes are in the quiescent phase for at least 6 months after the active disease. It involves alteration, loosening, tightening of the eye muscles, often over several operations, to improve the binocular vision. And the eyelid surgery is the final stage of any surgical approach and aims to adjust upper and lower eyelid position to improve the comfort and appearance. So this is the summary of treatment of Graves' ophthalmopathy. So the general measures include um, cessation of smoking, dark glasses with eyelid eye protection, control thyroid function to maintain the strict euthyroidism, prisms for the diplopia, and selenium supplements should be considered. And the specific measures include for the grittiness, artificial tears and simple eye ointment are used. For the eyelid protection, tape eyelids at night to avoid corneal damage. Surgery if there is a risk of exposure keratopathy. In patients with proptosis, head should be elevated during the sleep. Diuretics, systemic steroids, radiotherapy, and orbital decompression are the other options. For ophthalmoplegia, presents in the acute phase, orbital decompression and the orbital muscle surgery should be considered. In case of optic neuropathy, systemic steroids, radiotherapy, and orbital decompression um, can be considered. Thank you.